Good afternoon. As a class eczema, I am Dr. Shraddha. So the objective of this class is to recognize the different types of eczema. Mostly your visual class, it's very common complaint. Your eczema say detect. So it's just to recognize them, know the types, simple investigation and treatment objective as a class. So this is how an acute eczema looks like. Your acute eczema the skin appears very wet, oozy huncha, oozing गरेर हुन्छ, wet हुन्छ. Patient usually pani निस्किन्छ, चिलाउँछ भनेर complain गरिरहेको हुन्छ र यसलाई चाहिँ हामी acute eczema भनेर भन्छौं है. अब यो भने चाहिँ यहाँ स्किन ड्राई देखिन्छ, अघिको जस्तो वेट पनि छैन, उजी पनि छैन, ड्राई छ, स्किन मार्किङ्सहरु मोर प्रोमिनेन्ट छ. यसलाई चाहिँ क्रोनिक एक्जिमा भन्छौं. क्रोनिक एक्जिमा भने अलिक लामो समयसम्म भएको एक्जिमा जसको वेट क्यारेक्टरिस्टिक हटिसकेको छ, चिलाउँदा चिलाउँदा स्किन मार्किङ्स मोर प्रोमिनेन्ट भइसकेको छ. सो दिस इज क्रोनिक एक्जिमा. अब अर्को एउटा कमन चीज भने चाहिँ यो एलएससी भनेर भन्छ यसलाई. एलएससी को तीनवटा क्यारेक्टरिस्टिक्स हुन्छ. एउटा भनेको द स्किन अपियर्स मोर डार्क, जुन यहाँ कालो कालो देखिरहेको छ. स्किन मार्किङ्स आर अपियर मोर प्रोमिनेन्ट, सो यु क्यान सी द स्किन मार्किङ्स. अनि यो स्किन थिक पनि हुन्छ. जेनरली चिलाउँदा चिलाउँदा मान्छेको सिन अफ द फुट अथवा एकदम चिलाउने, कोहीले घाँटीमा चिलाउँछ, कोहीले टाउकोमा चिलाउँछ, चिलाउँदा 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 त्यहाँ स्किन डार्क हुन्छ, थिक हुन्छ, मार्किङ्स मोर प्रोमिनेन्ट हुन्छ. अनि यसलाई चाहिँ एलएससी भनेर भन्छ है. एकैछिन. So this is LSC, lichen simplex chronicus. अनि so this is another picture. यसमा चाहिँ कस्तो छ भने अलिअलि वेट एरियाज पनि देखिरहेको छ जुनमा क्रस्ट फर्म भएको छ. अलिअलि स्किन मार्किङ्स पनि देखिरहेको छ. दे हैव बिकम मोर प्रोमिनेन्ट. सो दिस इज बिट्विन एकदम अघिको एक्युट एक्जिमा जस्तो वेट पनि छैन, क्रोनिक एक्जिमा जस्तो ड्राई पनि छैन. यो बिचको स्टेज छ यसमा. And this is known as subacute eczemas. Okay. And so symptoms and signs of eczema, the most common sign that most patients complain about is itching. एकदम धेरै चिलाउँछ अनि पानी बग्छ. acute eczema छ भने पानी बग्छ. And then soreness, like अप्ठ्यारो महसुस हुन्छ. So these are the clinical signs of eczema. Symptoms भने आफूले देख्ने, आफूले elicit गर्ने चीजहरुमा चाहिँ रेड हुन्छ, जस्तै एरिदेमा भन्छ, जुन उजिङलाई हामी एक्जुडेसन भन्छौं. एक्जुडेसन हुनुभन्दा अगाडि सानो भेसाइकल्स हुन्छ, पानी भरेको फोकाहरु देखिन्छ, कहिलेकाहीँ पानी नभरेको फोकाहरु पनि हुन्छ. क्रोनिक एक्जिमामा इट बिकम्स मोर ड्राई, पत्र पत्र निस्किन्छ. सो दिस आर ऑल सिम्पटम्स अफ एक्जिमा. बट द मोस्ट क्यारेक्टरिस्टिक कम्प्लेन इज इचिङ. कहिलेकाहीँ इट्स भेरी रेयर that eczema presents without an itching. So there's always an itching, and it is the most common complaint that patients have for eczema. Next thing is histopathology. So clinically हेर्दाखेरि acute eczema मा अहिले अघि नै भनिसके there is lot of oozing, पानी निस्किरहेको हुन्छ है. So the histopathology of eczema मा चाहिँ what do we see? The hallmark is spongiosis. Spongiosis भनेको जुन हामीले क्लिनिकली हेर्दाखेरि यो पानी भरेको फोका देखिन्छ अथवा वेट लेजन्स देखिन्छ, त्यसलाई माइक्रोस्कोपको भित्र हिस्टोपैथोलॉजिकली हेर्दाखेरि चाहिँ एपिडर्मिसमा देयर इज फ्लुइड फिल स्पेसेस. सेरम चाहिँ इंटरसेलुलर स्पेसमा सेल्सहरुको बीचमा जुन नर्मली स्पेस नहुनु पर्ने हो त्यो स्पेसमा चाहिँ पानी गएर भरिएको हुन्छ. एन्ड दैट इंटरसेलुलर स्पेसमा जुन पानी भरिन्छ त्यसलाई चाहिँ हामी स्पोन्जियोसिस भनेर भन्छ. सो दिस इज एन hallmark, histopathological hallmark of acute eczema. And if you guys have to answer MCQ मा आउँछ what is the hallmark of acute eczema, so the answer is spongiosis. त्यो भए क्रोनिक एक्जिमामा लाइक आई सेड स्किन मोटो हुन्छ. स्किन मोटो भएपछि हिस्टोपैथोलॉजिकली स्किनमा के हुन्छ? एपिडर्मिस हुन्छ, डर्मिस हुन्छ. मोटो स्किनको एपिडर्मिस मोटो हुन्छ, त्यसलाई हाइपरकेराटोसिस भनेर भन्छ. अनि त्यसको डर्मिस पनि, त्यसको लोअर पार्ट अफ एपिडर्मिस रेटिडिजस पनि मोटो हुन्छ, त्यसलाई क्यान्थोसिस भन्छ. पाराकेराटोसिस भने चाहिँ नर्मली तलबाट माथि जाँदाखेरि एपिडर्मल सेल्स लूज देयर न्यूक्लियस. सो इफ न्यूक्लियस is present, that is known as parakeratosis. So these are other features that are present in eczema. So the characteristic is spongiosis. Apart from that, you have hyperkeratosis, acanthosis, parakeratosis. So we all like to classify things. The whole science is based on classification systems and classification of eczema. So how do we classify eczema? Based on morphology. Morphology भनेपछि appearance हो है. Phase अघि नै मैले भने acute भने wet खाले eczema, chronic भने dry खाले eczema, अनि subacute somewhere in between acute and chronic eczema. And the other is endogenous and exogenous. So in all eczemas, there is also mention say eczema as a commonly allergy one. So everybody thinks that allergies have some reason, yo khaira, tyo khaira. So all the time allergies are not because of something else. Eczema is not because of something that we can pinpoint in the environment. And they can be endogenous, bhitre bata hune eczema. So that is endogenous and exogenous eczema. And exogenous it differs on the etiology. It can be irritant and allergic type of eczemas. So one common question that is often asked in your exams is to differentiate between irritant and allergic eczemas. We will discuss about them as we move ahead. And this is the various type of endogenous and exogenous eczemas. It's just important that you know the names of these eczema, and we'll discuss a bit about some of them later, right? And so now we come to irritant versus allergic. So what is the main difference of irritant eczemas versus allergic eczemas? The main key difference between irritant eczemas and allergic eczemas is that there is an immunologic memory in case of allergic eczemas, which is not there in case of irritant eczemas. Now some pictures of what people do in our part of the world. So you can see some people, yeah, ghas katiraheko, ढुङ्गा गरिरहेको, त्यसपछि भाँडा माझिरहेको, then रोपाईको, and then घाँस काटिरहेको again. So all these kind of activities, which is very common in our part of the world, if we also start doing them, जसले गर्छ हामीले पनि गर्न थाल्यौं भोलिदेखि भने our hands end up like this, right? This is the end result. So this can happen to anybody who will be involving in these kind of works. So why does this happen? This happens because all these works, they damage the integrity of our skin. Our skin ko jun defense mechanism huncha, repair mechanism huncha, त्यसलाई damage गर्छ यो सबै activities there. So constant exposure to dirt, constant exposure to soil, constant exposure to vegetation, constant exposure to all kind of surf or animal को त्यो दूध दुहुने or गोबर सोर्ने, त्यो सबै चीजहरुले चाहिँ हातको छालाको integrity लाई damage गर्छ. त्यो integrity damage भएपछि जुन त्यहाँ भएको allergens हरु हुन्छ तिनीहरुले चाहिँ हाम्रो छालामा सजिलै they can enter. So after entering our skin, they cause an inflammatory response. So this happens to anybody. There's no need of any specific immunologic memory or specific immunity, immunity सँग related केही पनि activate हुनु पर्दैन. यो जसलाई पनि wear and tear, constant त्यो repair mechanisms हाम्रो जुन skin को repair mechanism हुन्छ त्यसलाई चाहिँ यसले destroy भयो भने this tends to happen, and this is known as irritant dermatitis, also known as wear and tear dermatitis of the skin. So here we can see an irritant dermatitis to gloves. So sometimes constant wearing of gloves and some kind of material in the gloves, they tend to irritate the skin and it can cause irritant reaction to the gloves. This is someone just a plant को bulbs like दुईटा हातको टुप्पाले छुइराख्छ चलाइराख्छ त्यस्तो मान्छेहरुलाई यो ठ्याक्क हात समात्ने ठाउँमा irritant reaction भएको छ. So this is fingertip eczema. This is also an irritant contact dermatitis to plant bulbs. अनि यो चाहिँ एकदम कमन छ हाम्रोमा, स्पेशली तिमीहरुको हस्टेलमा पनि एकदम कमन छ. There are some linear irritant lines पोल्ने चर्याउने हुन्छ, and this is also known as Pedrus dermatitis. एउटा insect हुन्छ which is known as the Pedrus beetle, and this releases a substance known as pedrin. र यो pedrin भन्ने substance ले चाहिँ जब skin लाई irritate गर्छ, then we get this irritant contact dermatitis, also known as Pedrus dermatitis. So now we talk about allergic contact dermatitis. Right? Allergic contact dermatitis, there are phases. There is a sensitization phase and there is an elicitation phase. So sensitization phase is the first phase when we are exposed to some allergen. So these allergens, they bind to the Langerhans cells. Antigen presenting cells of the skins are known as the Langerhans cells. Now these Langerhans cells, they move upward in our lymphatic system and they move to the regional lymph nodes, right? Lymph nodes ma gaera त्यहाँ भएको T cells हरुलाई चाहिँ यो Langerhans cells ले antigen present गर्छ. After that they get activated and there are specific T cells form हुन्छ. This first exposure ma the person may not develop a very significant reaction to that particular substance in the first exposure, but on subsequent exposure, when there is a re-exposure, now the T cells are already activated, and once the antigen presenting cells they catch those allergens, they present to those activated T cells, and there is a immediate, almost an immediate and early response as compared to the first time based on the immunologic memory. So this is known as allergic contact dermatitis. Now, allergic contact dermatitis can happen to all these allergens. One is nickel, nickel jun button ma huncha, jip ma huncha, jewelry ma huncha. Like many girls, they tend to get dermatitis in the ears, the fake jewelry lagaera. Sometimes people get it on the belly button area, jip buttons they got the hairy, they get because of the zippers. Chromate भनेपछि usually leather मा हुन्छ, leather को जुन dyeing process shoes, जो original leather shoes हरुको dyeing process मा chromate use हुन्छ. Cement is another very common allergen, so cement मा पनि chromate हुन्छ. A lot of people are allergic to hair dye, so the allergen component of hair dye is paraphenylene diamine or PPD. They say para-tertiary butyl phenol, which is present in bindi, PTBP भनेर भन्छ. यसले पनि एकदम contact dermatitis गर्छ. कहिलेकाहीँ यसले त skin को त्यो color, the melanocytes लाई पनि damage गरिदिन्छ. So there can be even contact leukoderma or contact vitiligo because of this PTBP chemical. Multiple agents in the footwear can cause footwear dermatitis. The footwear मा sometimes rubber is there, other latex is there. All these things can cause contact dermatitis. So this is all forms of allergic contact dermatitis. Like we can see in this picture, there is a girl and she has developed an allergic contact dermatitis to nickel. So nickel allergies are we often notice that first time, yeah, for some time when people wear earrings, initially keep any reaction hudaina, but after several times, sometimes people start developing an allergic contact dermatitis, and once it has developed, people develop an allergic response and they cannot wear it any longer. So this is an allergic contact dermatitis. This is where the your belt ko nickel, your particular thing ma nickel huncha, nickel touch gare ठाउँमा the person has developed an contact dermatitis. This is because in the slippers, the rubber ko chappalharma rubber ma bhayeko jun substance huncha त्यसले allergic contact dermatitis गरेको हुन्छ, footwear dermatitis भनेर भन्छ. So hawai chappalले गर्दा हुने dermatitis. Here the woman wears bindi. यो बिन्दीले गर्दाखेरि para-tertiary butyl phenol जुन हुन्छ बिन्दीमा, त्यो बिन्दीले गर्दा भएको dermatitis भयो. This is also bindi dermatitis. So this woman always wears bindi, and the bindi has resulted in dermatitis. Also, people have dermatitis because of the sindoor. Sindurle गर्दाखेरि सिन्दुरमा भएको chemical, which is also there's some kind of dye that causes an allergic contact dermatitis. So these are all various examples of allergic contact dermatitis. There is always a sensitization response and an elicitation response. Hence, first exposure the person might not get much of a allergy or eczema, but on subsequent exposure they might get. The same thing happens with hair dye also. A lot of people say that I've been using this hair dye for 10 years, nothing has happened to me, but after last exposure, every time I use it, there is some reaction to it. So the sensitization process might take a long time, but once the sensitization has occurred, there is always an elicitation response, and therefore, allergy they should always stop using that product. So the next thing that we talk about is airborne contact dermatitis, or ABCD. So it's not anybody can dance, so it is airborne contact dermatitis, ABCD. It is mainly caused by something known as Parthenium hysterophorus. Parthenium like this is not yahako jun original plant se hoina. This has been imported from other parts of the world, mostly from the North America. So it came as a weed along with a shipment of wheat that was supposed to come to India from America. And then after coming to India, it has spread all over the Indian subcontinent, India, Nepal, sabbaitira spread basa. And this plant, Parthenium, is responsible for a lot of contact dermatitis in our part of the world. And dermatitis as airborne contact dermatitis because this Parthenium releases pollens, and these pollens, they are present in the air, and they come and stay at different parts of our body and cause dermatitis. So this is a typical feature. What is typical about this airborne contact dermatitis is it affects the areas of the body that are exposed, like the face is exposed, the neck is exposed, the part of chest is exposed, tummy, back is to area relatively spared also, and exposed parts of the body. And another thing about airborne contact dermatitis is jun area flex bhairaheko huncha. Like for example, this area, cubital fossa. So this people keep flexing and extending these areas, and in these areas, a lot of airborne contact, these pollens, they can just stay here, and in this area or in the neck or in the eye folds, these pollens can stay there and irritate the skin. So airborne contact dermatitis is more prominent in the folded areas of the skin. This is another example. She is present all over the face. She has it on the chest. And how do we test for these various type of contact dermatitis? How do we know we are allergic to nickel or dye or something? How do we prove it? So we prove it with the help of something known as patch test. Yeah, we don't have patch test, but patch test is the way of testing if you are allergic to nickel or chromate or bromide or some PPD or some other dye. So what do we do in patch test is we have strips. Is the strips huncha, त्यो strips ma गोलो गोलो हुन्छ. यो गोलोमा चाहिँ aluminium को, there are these aluminium little discs, and inside them we put your injecting chemicals, say certain dyes, or there are certain products जस्तो एउटा series हुन्छ, series fragrance series हुन्छ, कुनै कुनै fragrance हरुको concentrated series हुन्छ, or there are those खुट्टामा लाउने footwear series हुन्छ, dye series हुन्छ, textile series हुन्छ. So the most common allergens that are present in textiles or dye or in the environment, or त्यो सबै चीजको चाहिँ collection हुन्छ, and these are applied on this little tube wells. यो well जस्तै हुन्छ भने बट्टा जस्तो हुन्छ, अनि यो बट्टामा apply गरेर it is pasted on the elephant chamber भन्छ. So it is pasted on people's back, है, ब्याकमा राखिदिन्छौँ, अनि ब्याकमा राखेर यो टाँसेर नै 2 दिनसम्म छोड्दिन्छौँ. लाइक आज टाँस्यो भने पर्सिको दिन पेशेन्टलाई बोलाउँछौँ, and पर्सिको दिनमा चाहिँ after 2 days we remove this patch test, and after 4 days, so we test once, एकचोटि after 2 days हेर्छौँ and एकचोटि after 4 days हेर्छौँ. So how do we do the patch reading? Patch reading मा चाहिँ many things can be present. So if there is mild erythema, you know, it is doubtful, यो हो कि होइन भनेर भन्न गाह्रो हुन्छ. But if we see these small papules, small vesicles present, it is known as 1+ भनेर भन्छ यसलाई, weak positive reaction भन्छ. Mostly there is this erythema and some papules might be present. So this is known as 1+ reading. Then there is this 2+ reading. When I say if there is papules present and prominent vesicles present, then that is known as 2+ reading. And if these papules, vesicles plus big bulla is present, it is known as 3+ reading. So 1+, 2+, 3+, those people are definitely having contact dermatitis. That is like a proof that, okay, this thing the contact dermatitis, and if you avoid that thing, you will avoid this allergic response. But sometimes even when we do this patch test, there might be a confusion between whether it is irritant or whether it is an allergic test. So if it is an irritant, हामीले जब त्यो 2 दिनमा निकाल्छौं त्यो patch chamber, त्यो बेलामा reaction present हुन्छ, तर 4 days मा निकाल्दाखेरि it is negative. So that indicates that it is an irritant reaction, because in irritant the reaction is present just till the time the substance is applied to that particular area, whereas in allergic reaction the reaction will be present even after the substance is not applied to that area. Because patch test, we apply the patch for 2 days and then we let the patient go, and then we again test the patient on the 4th day. Main चीज इसबाट बुझ्नु पर्ने भने चाहिँ के हो भने, there is something called patch test. Patch test is used to check if there is a contact dermatitis. Patch test को reading say weak positive, strong positive, extremely positive हुन्छ, and patch test is applied on the back of the patient. It is checked on day 2, and then the patch is removed, and day 4 मा चाहिँ again the patch is checked. So this is the test by which we know if somebody has a contact dermatitis or not. Sometimes this might be a part of your viva. K test garcha to know if there's a contact dermatitis. Do not say that there is some blood test or something. There is some test which is known as a patch test, in which you apply the chemical which you think is responsible for causing contact dermatitis, and it is applied on the back of the patient, and you check it on day 2 and day 4. That is all we need to understand from this part. And finally, there is the difference of patch test between allergic and irritant reaction is that in allergic reaction, it is present up till it is present usually on day 2, and it is absent on it is always present on day 4 also. Whereas in irritant reaction, the persistence part is not there. Like it is present on day 2, but it is not present on day 4. Also in allergic reaction, the reaction is limited to that, is extends beyond that area, whereas in irritant reaction, it is sharply demarcated. The other things are also there. You can read it yourself. Now, this is an important chart for you people, because this is what is actually asked often in exam. What is the difference between irritant and allergic reactions? So irritant, there is no immunological memory. It is just based on direct tissue injury. Whereas in allergic, there's an immunological memory and type 4 reaction is evoked. Histology is almost same, but in irritant, because there's a direct damage to the tissue, there are also necrotic keratinocytes are present. Whereas in allergic contact dermatitis, there's more of spongiosis or dermal infiltration of lymphocytes, because lymphocytes are activated by the Langerhans, this antigen presenting cells. So this is all present in allergic reaction. Occurrence after first exposure is present in irritant contact dermatitis, because there's a direct tissue injury. So acid le gardakheri hos or the pidus dermatitis le garda hos, even on the first exposure you will get a reaction to it. Whereas in allergic, in the first exposure there's often no reaction. Sensitization matra bhayeko huncha. So first exposure ma there might be no reaction, no form of reaction when it comes to allergic contact dermatitis. Onset, it is immediate in irritant contact dermatitis, whereas in allergic contact dermatitis it does take some time, like 24 to 48 hours for the onset of the reaction. Cross reactivity is rare, whereas cross reactivity is common in allergic, because immunologic memory bhayeko karanle garda certain group of flowers, like euta group of plants ko, if one flower can elicit an allergic contact dermatitis, another flower of the same group but different plant can also elicit an allergic contact dermatitis. Like godavari ko jun फूल छ यसले कति मान्छेलाई एलर्जिक कन्ट्याक्ट डर्मेटाइटिस एलिसिट गर्न सक्छ. गोदावरीकै ग्रुपमा हुने अर्को डेजीको फूल अथवा अरु कुनै खाले फ्लावर which belongs to the same group can also elicit an allergic contact dermatitis in that people who have been sensitized to one type of flower from the same group, right? And there is no specific test for irritant contact dermatitis, whereas for an allergic contact dermatitis, a patch test is a specific test. This is an important chart, and sometimes the questions are asked based on the difference between irritant and allergic, and I think we should remember. Complications, sometimes people do not take care of this eczematous state, the oozy state, so they will apply some local home remedy or not take care of it. Skin barrier त्यो बेलामा स्ट्रङ हुँदैन, त्यसैले गर्दा many infections can take place. एरिथ्रोडर्मा भन्ने चाहिँ कहिलेकाहीँ इक्जिमा फुल बडीमा स्प्रेड हुन्छ, स्पेशली एयरबोर्न कन्ट्याक्ट डर्मेटाइटिस छ भने अथवा सिभियर एक्सपोजर टु सम काइन्ड अफ एलर्जिक कम्पोनेन्ट्स भने इट क्यान स्प्रेड टु होल बडी एन्ड द होल बडी क्यान गेट रेड, that is known as erythroderma. Psychosocial complications are also important, like it can lead to anxiety. A person who has once developed eczema which has spread to different parts of the body, like airborne contact dermatitis, they might get anxious that फेरि पनि हुन सक्छ कि, they might be depressed because they have to always itch and scratch that particular area, so that can lead to depression. Social complications, it might be it might look ugly, like LSC lesions or lichen simplex chronicus. There's a dark lesion that keeps itching at some prominent part of the body. The people might feel conscious about it. It can lead to social complications, and it can also lead to debilitation. If you keep scratching a particular part of the body, it can debilitate your other activities because you feel like you have to keep itching that area. So the management is, the first most important management is to avoid the allergen. Do not just, if possible, like a contact dermatitis, allergic contact dermatitis ko test garyo and you get the patch test positive to nickel, let's say, then you avoid everything that has nickel. Like you avoid the jewelries, you avoid the buttons, you avoid everything that is the allergen present. The next thing that we as dermatologists do is topical steroids. So there are different kind of topical steroids. The potency for topical steroids moves in this direction. Usually, initially, a mild savanne, we start with something in the lower potency like desonide or hydrocortisone. And if it is very severe or chronic reactions, we use something as clobetasol or halobetasol. But one should remember that these very potent steroids should not be used in areas of the body like flexors, genital area ma, flexural areas ma, eyelids ko mathi जहाँ skin thin huncha, जहाँ absorption hune chance बढी हुन्छ, त्यो ठाउँमा चाहिँ topical steroids with high potency should not be used. Also, high potency topical steroids should not be used on small children. So if it is very severe, it is all throughout the body and लगाएर मात्र application ले मात्र possible छैन भने we give a course of oral steroids. It can be 0.5 to 1 mg per kg per day, or we use steroid sparing agents such as cyclophosphamide, azithromycin. Maintenance को लागि emollients are very important. Emollients भने तेल, vaseline यस्तो चीज हो. Actually अब irritant contact dermatitis मा त obviously the skin integrity is damaged, so integrity damage नहोस्, skin लाई एउटा cover जस्तो होस्, protection जस्तो होस् भनेर पनि we tell all our patients to use emollients. One of the most common advice that we give in our dermatological OPD is keep applying. तेल लगाउनुस्, नरिवलको तेल लगाउनुस्, vaseline लगाउनुस्. So emollient application protects the skin from more damage from the surrounding, from irritant objects that are present. So applying emollients is necessary. Next thing that we are talking about is photodermatitis. Photodermatitis भनेको lightly हुने dermatitis लाई चाहिँ photodermatitis भनेर भन्छ. So photodermatitis को एकदम typical distribution हुन्छ. Photodermatitis चाहिँ उज्यालो ठ्याक्क light पर्ने ठाउँ जस्तो forehead मा हुन्छ, nose मा हुन्छ, cheeks मा हुन्छ. यो usually यो underside of the chin मा हुँदैन, घाँटीमा पनि कम हुन्छ, तर फेरि यो neck area ठ्याक्क expose हुने एरियामा बढी हुन्छ. आर्म्सहरुमा पनि expose size बाहिरको साइडमा बढी एलर्जी हुन्छ, भित्रको साइड almost spared हुन्छ. खुट्टामा पनि खुट्टामा अब यो flexus यो पछाडीको एरियामा कम expose हुन्छ. अघि airborne contact dermatitis cubital fossa अथवा यहाँ पछाडीको popliteal fossa तिर बढी हुन्छ भने यो airborne contact dermatitis चाहिँ त्यस्तो एरियालाई usually spare गरेको हुन्छ, छोपिने एरियालाई spare गरेर बाहिरको एरियामा इन्भल्भ भएको हुन्छ. So you can see here in the chest it is present. यो बाहिर expose हुने एरियामा चाहिँ light यो photo exposed area हुन्छ. अरु patterned eczemas मा there are other patterned eczemas. This is also known as nummular eczema. Nummular eczema भने coin shaped eczema हो. This is pretty common. बच्चाहरुको पनि भइरहेको हुन्छ coin shaped eczema here and there. So these are known as nummular eczemas. Eyelid मा हुने eczema is आँखामा हुने eczemas is known as eyelid eczema. Eyelid eczemas are commonly seen in people who have atopic dermatitis. We'll talk about them later. Pompholyx भनेको यो पानी भरेको vesicles हुन्छ जुन हातहरुको बीचमा आउँछ. Sometimes some of you might also have it seasonal पनि हुन्छ, season change हुने बेलातिर यो कहिलेकाहीँ बढी आउँछ. So this पानी भरिएको lesion between the fingers, this is known as pompholyx. Prurigo nodularis भन्ने चाहिँ यो सानो prurigo त्यो चिलाउने lesion हुन्छ, then people keep itching them. So if they keep itching them, they become nodular lesions. So this is known as prurigo nodularis. These are typical hereditary eczemas. So if somebody shows you in the community कसैलाई, so you can show off and say this is, if you can recognize the lesion, you can always say this is prurigo nodularis. This is a pompholyx, eyelid eczemas, nummular eczemas. The treatment for all these kind of eczemas is topical steroids in most cases. Unless very severe, we almost never give oral steroids. Prurigo nodularis, if it is present all throughout the body, we might need to give oral steroids or steroid sparing agents. In eyelid eczemas, we should never give strong high potency steroids, and low potency steroids are usually the management for eyelid eczemas. And so there are some questions when you go through this presentation later, you can ask yourself. So, and you guys have any questions? So if you have no questions, then we'll end today's session.